more interested in coming back to campus to do it, or would you prefer to present somewhere like a state or national meeting? What are y'all's thoughts? Neither is not a choice. You'll have to present somewhere. So you guys would all be interested in coming back to campus in, say, like April before you graduate in August to present your research?
Could we do it like the week of graduation? Like
No,
maybe like the prior? No.
no. Because people that don't get their stuff together, graduation paperwork will already be processed. And that was one of our concerns, was that's additional expense to have to come back to campus. Yes, you would get out of clinicals for it. You get out of clinicals no matter what. Like if you go to the Texana meeting and present, you get out of clinicals to go to that. If you go to Congress or ADCE, you would get out of clinicals for that. So the clinical days off is not a big deal. The concern is just like the trip back for folks. I know it's really easy if it's just down the road for you, but if you're coming from out of state, it would be additional cost for you. So that was my concern, especially for it. Tyler's question, if the majority want to go to campus, can those that don't go to a state one? And that's definitely something to consider. The problem with doing an online conference, and you guys just have to be real with yourselves, we can't get people to show up to class and pay attention. Somebody showing up for a day of online conference is not going to be real productive. And it wouldn't be fair to have one member of the group have to travel and not have the others. We've talked about that, and we may try and see how it goes. But I just don't think that that would be real productive. I know other programs require everybody to come to campus. How would you guys feel if a deadline was set for you to do a national state meeting, and if you didn't present there, then you would have to come to campus and present? Would that be a viable option for folks? Because there's lots of state and national and regional meetings you could go to. I know at that point in the program, money is really starting to get tight, and an extra trip that you hadn't accounted for would not be fair. And this is something that we're just discussing. It's not something being forced upon you right now. How much time do you guys think you would need to pick a conference? Do you think if you started planning it out when you begin your DSW stuff, that would be okay? Ray's question is, how are they currently doing it? And right now, it's just kind of been left up in the air and it hasn't really been tracked. And that's one of the things that, from a program accreditation standpoint, we're trying to revise. So they're currently just doing whatever. Some of them are just doing department meetings. Some of them are doing like state meetings. Some of them are doing national meetings. So there's quite a bit of variety, but it's not really been well tracked. No, it would not count as your conference requirement for graduation. You're still going to need to go to a state or national conference. Now, what I will say is if you were presenting at a state or national conference, usually they give you free registration or discounted registration. So you might be able to kill two birds with one stone and save yourself some money there. So that may be an option for you too. And that would count as a conference requirement, but coming back here for just the research conference would not. All right, well, I just kind of wanted to get you guys thoughts and insights. We were just discussing it in faculty meeting this morning, and it's kind of been an ongoing topic of discussion. So we'll go from there. Raquel asked, we would need to know our enrichment rotation schedule to plan it. As I said, it would be days off. We would try not to take away from your clinical experience. So we, if we pick that, we would try not to have clinical rotations that time, it probably wouldn't work out that well for everyone. So somebody would probably still be on a rotation somewhere. With that being said, people still wind up missing a little bit of stuff from rotations. We just try not to take vacation if we can help it. Let me just scribble some notes real quick. Okay. Nathaniel asked, conference dates and locations are usually set about a year in advance. Yeah, national stuff is usually set a couple years in advance, so you know that pretty well. State meetings are generally 6 months to a year as far as locations. And with that being said, if you apply to a state meeting as a resident, they almost always take your paper or your poster. And like I said, it discounts your registration if it's not free. Ray asked, can it be disseminated locally at the hospital annual process improvement nursing grand rounds? The problem we've run into is dissemination has really turned into a 5-minute talk at the bedside for people that are doing it at the hospital level. Some places, like say for instance, your hospital has a research conference, that would be a viable option for you. We just wanted something more formal than you talking to somebody for 5 minutes in the lounge or talking to a couple somebodies. So that was part of the problem we've run into there. And then any sort of documentation that comes out of it. I'll give you for instance, JPS has a research conference every year. That would be an acceptable dissemination method, or, whatever your hospital is, if they have something, or, the university they're affiliated with has something to that effect, that would be a possibility. Discussion as far as like financial aid on raising the cost of attendance for all this additional travel. We're trying not to raise the cost of attendance at all. I understand that if we do that, it's more money in your pocket, but it's still more money that's got to go be repaid at some point. So we're trying not to increase that cost if we can help it. Like I said, I understand at that point, you really start getting into financial kind of dire straits as you're headed towards the end of the program. A lot of your money's run out at that point. That's something we could certainly look at. Just from my personal standpoint and experience, if we can not put more money or more financial burdens on you guys, I think it would be a little bit better. But that's just my thought. Well, we know how Kristen's paying for school. All right. Well, thank you guys for the input. I just kind of wanted to get your thoughts about that. Is Feet Finder the one where you sell pictures of your feet and your socks and stuff? We're not going to get into how Ray's financing things. All right. Moving on to more productive things. So we had 2 cases to look at. The first one was a 67-year-old coming in for a FemPop bypass. This is a very real vascular patient. You're going to see these people, whether they're coming in for true vascular surgery or like AV fistulas and that sort of thing, that this is exactly what these patients look like. They're all sick. They're all at the end part of a disease state. That's usually why their kidneys have shut down. So when you have vascular injury to other vessels, it's not real surprising that you've had vascular injuries to your heart as well. So a patient had an inferior posterior wall MI 8 months ago, now has occasional angina. They had a scan done that shows 2 reversible defects. Patient refuses cardiac catheterization. So you'll see a lot of these people are pretty non-compliant with stuff. They may be only coming in to have this FemPop bypass done because their activities are limited or they're in excruciating pain. You'll see a lot of vascular patients show up in the middle of the night with like cold legs. Arms are not usually so much of a problem, but cold legs, cold feet, pretty common there. They're always on a variety of cardiac medications. Of course, they have the penicillin allergy that doesn't matter. These patients almost always smoke or have smoked. There are exceptions to that, but you'll see that's pretty commonplace. So this is kind of a classic vasculopath that you'll see come in. As I said, a lot of times these are urgent or emergent cases because they do have potential for limb loss. Labs, hematocrits 38. One thing I would certainly take into consideration with this patient, knowing that they smoked 2 packs a day, is they were probably hemoconcentrated when that lab was obtained. So if you give them any sort of fluid, you're probably going to see that they start to drop their hemoglobin pretty quickly. Renal function's not real spectacular. EKG is kind of blah. Patient has a good NPO status. So when you start thinking about this patient, first thing that obviously jumps out at you is their cardiac history. They were supposed to have a cardiac cath done and they've refused to do it. So you know they've got a bad heart. And it's not going to get any better under anesthesia. That's just the reality of the situation. So in a perfect world, we would let these people go at least a year. 6 months is kind of the minimum before we consider doing stuff that's elective, if you will. The downside of this patient is that we know his coronaries are still bad and they have not been fixed. So they've kind of been maximized as much as they can from a medical standpoint without any sort of surgical intervention, which is what they're refusing. So big thanks for that. Rate control, usually it's going to be with a beta blocker or calcium channel blocker. They've got PRN medications for their angina. So when we start looking at this patient, the first thing that comes to mind is I'd rather not put them to sleep if I can help it, because there's all these big issues that go with induction on somebody that's got bad coronaries and has already had an MI and is just waiting to have the second one. I'd rather not be the reason they die. So options I consider for that patient, regional anesthetic would be nice. This is a lower extremity thing, so you could also consider neuraxial with a spinal or epidural. Concerns that come into play when you start thinking about neuraxial, any of your vascular cases, if they're not already anticoagulated, will definitely be anticoagulated intraoperatively. So you could consider putting in an epidural catheter, leaving it in there for X amount of time if they're not already anticoagulated, and then stopping the anticoagulants and pulling it. They do still have an elevated risk of epidural hematoma, which could obviously be problematic for this patient that already has decreased sensation and is trying to be dead anyways. So that would be a possibility. Of course, the patient's refusing to have any sort of regional anesthetic done, which would really be my first choice. For something like a FemPop, you can pretty easily put in femoral and sciatic catheters and get good analgesia for the case. But unfortunately, the patient doesn't want to comply, which is pretty common for these vascular patients. They get to be kind of difficult. When you throw in the vascular renal patients, they tend to get a little bit worse. So they don't want to make our life easier. So the reality is that they've essentially forced us to put this patient to sleep because we don't have a whole lot of other options for the patient. So things to think about, as I mentioned, perioperative MI is a big concern. About half the people that will have a reinfarct intraoperatively generally wind up dead. Again, we don't want to be the proximate cause of their death, so we'll do everything we can to prevent it. From an anesthetic standpoint, normal monitors, if you're just using a 3-lead, I would make sure you had a 5-lead available so you can monitor the patient for intraoperative ischemia. I would put in an arterial line before induction, so awake arterial line. That way, as you're going to sleep, you're able to monitor their blood pressure. They've got a good NPO time, so we're not worried so much about some sort of aspiration from reflux, so at least we've got that going for us. The nice thing you'll see with that is if you are able to do a more gradual induction, the patients generally do a little bit better from a hemodynamic standpoint. So you can give a medication, wait and see what it does to your hemodynamics, then give another medication. It's not like somebody with a full stomach where you have to do a rapid induction to avoid the risk of aspiration. So get them intubated. As I said, during that induction process, if you move slowly enough, you can address hemodynamic changes as they happen. So if you give medication X and it lowers your blood pressure, then you're able to treat it with another medication. Things I would consider having in line already for this patient, I would probably go ahead and have phenylephrine or norepinephrine on a pump, and I would probably also have nitroglycerin available, not only just for their cardiac issues, but also for blood pressure control intraoperatively. Generally, what I'll do for any of my vascular cases, all the way from a AAA just down to something simple like a FemPop, is I'll have nicardipine and phenylephrine in line, as well as pushes available. So if the patient does experience an intraoperative MI, usually it's going to be recognized by ST segment changes. Usually it's going to start off with depression, but you may see some elevation as well. It really just depends on where they're at in the course of their MI. Try and maintain normotension, because we know the demand ischemia is one of the biggest reasons that they're going to wind up infarcting. So if we're able to make gradual changes with the patient, it's a little more beneficial. As I said, it's helpful if you've got nitroglycerin in line that you can use to kind of help reduce the myocardial oxygen demand and increase their coronary blood flow. Avoid tachycardia if you can in these patients. In addition to keeping them normotensive, we also want to keep their heart rate within normal limits. You know they're already on a beta blocker, so you may consider an additional beta blocker dose. A lot of time to intraoperatively for a little bit longer time periods. We will go ahead and use an esmolol infusion, but because it allows us to achieve a steady state. You'll see some places they use like IV low pressure. The problem is if you're giving IV low pressure, you kind of have these peaks and valleys, whereas something like esmolol, especially if we're trying to avoid tachycardia, would really be ideal, and we can run that as an infusion. If they do become hypotensive, as I said, phenylephrine may be an option. Norepinephrine would probably be my second choice. Some people will say go to dopamine. I generally try and avoid dopamine in cardiac patients if I can help it, because it does tend to lead to tachycardia. A lot of times you won't see that with something like norepinephrine. If you do have any sort of ventricular ectopy, remember your first treatment is going to be oxygenation of those coronaries. So if you need to increase your oxygen requirement or oxygen supply, that would be beneficial. And then I'd consider something like nitroglycerin. Finally, as the last choice, if you really feel like you need to treat the PVCs, or they start turning into a short run of VTAC or something like that, consider lidocaine or amiodarone. So those are really the big things for this patient. If you're not forced to go quickly, take your time. Gradual inductions are generally pretty easy for these patients, because you will see lots of hemodynamic swings. The most likely time for them to have ischemia is going to be during induction or post-induction, but it may take a couple minutes to really start to declare itself. So you may not see those EKG changes for a couple minutes thereafter. All right, what questions did you guys have about this case? All right, we'll move on to the next one. So Katie asked, if your patient is having an MI intra-op, do you stop the surgery? It depends on where you're at in the case. So say, for instance, you've got somebody that's prone for a back surgery. If you've already got their back open, you kind of have to decide at that point, can you quickly finish the case? Because you're going to have to close either way. If they're not in actual cardiac arrest, you're going to have to get the site closed. If you do have somebody that's already in arrest, a lot of times what we'll do is just put a dressing or a towel over it and flip them supine for resuscitation. With that being said, there's a little bit of evidence that kind of supports doing prone chest compressions. Some of that comes from the operating room. Some of it comes from like COVID stuff. So usually you're going to try and stop the case as soon as possible. It's just how soon is that possibility? And you've got to have communication between you and the surgeon for kind of determining, what's going on. None of them want to have their patient die. So if you let them know that they're having EKG changes, they'll kind of let you know if they're at a point where they can stop, where they can close quickly, stuff like that. So yeah, you're pretty much going to stop the case as soon as possible. As I mentioned, a lot of times if you have ischemia, it's going to happen post-induction. So what'll happen is you start putting the patient to sleep, you put them to sleep, they start having ischemic changes, and you just stop and wake them back up. So it usually will happen before you actually make incision. So yeah. So then you think the patient's having an MI or having some sort of ischemic event. You stop, you wake them up, get them over to recovery. You're going to consult all sorts of people. So you're going to call cards, you're usually going to have like a hospitalist or a medicine service that's actually going to manage the patient. Some places cardiology will do it themselves. So it's kind of like a one-stop shop. You call the hospitalist, and then he's going to take care of calling cardiology for you, or you call the admission team or whoever it happens to be at that facility. So part of it's just having that relationship. We'll go ahead and start like an initial cardiac evaluation. So get him over there, get a 12 lead EKG, because sometimes what you see on a 3 or a 5 lead EKG isn't what it really looks like when you get a 12 lead. It could be lead positioning, it could be the patient. The other thing is you may see that it's like a demand ischemic event where during induction, maybe they had a period of hypoperfusion. So as part of that, they had a little burst of ischemia. Post-induction, when those medications wore off or you treated them and got their blood pressure back up, those EKG changes may have resolved. So that's something for you to think about. They will usually still have a troponin bump or a PK bump at that point. But we generally, unless you have some sort of like guideline or protocol, try and stay out of going too far down the cardiac workup, because as you start doing that, then you start being responsible for the outcome of stuff. The exception to that would be like if you talk to cardiology and maybe he's driving in from home or something and asked if you'll go ahead and do X, Y, and Z. And in that case, you may go ahead and do a little bit more as far as the workup goes. Ray asked, do you find that norepi is less effective in these chronic hypertension patients? Norepi tends to work pretty well. What you will see is less effective is your ephedrine and your neosynephrine. A lot of times in these patients, they don't respond real well to single agents. So like somebody that you would normally give a bolus of phenylephrine, they may not respond. So maybe if you do phenylephrine and ephedrine together, you get a response. But a lot of times, especially if they're on ACE inhibitors, you may see that you kind of have to step it up to something like vasopressin or a norepinephrine bolus to try and get your pressure back up. The nice thing is most of the time it's not a surprise. You know what medications the patients have and have been taking. So usually if I have somebody that's continued like an ACE inhibitor up to the day of surgery, I'll go ahead and make sure I've got some vasopressin available if not drawn up. Pushes for vasopressin work a little bit better in this situation than infusions do, just because of the low rate you usually see with the infusions. So like I said, this is a pretty standard cardiac patient. You've got some social issues thrown in. They've had an MI. They don't want to get cath. They don't want to have regional stuff. Sometimes people are just difficult to deal with. From an anesthesia standpoint, we just try not to be the reason they die. And sometimes it's just you need to say no. You may not be able to do it for somebody that's got a cold leg, like they're to the point of no perfusion. But if it's just somebody like this with claudication, you may consider putting off the case until they can be a little more cooperative. And the other part of that is have a frank discussion with the patient. My concern about putting you under anesthesia is you've had this recent MI. It has not been treated. I don't want this surgery or this anesthetic to kill you. Sometimes when you talk to patients and you're blunt and say stuff like that, they kind of get the point that, oh, maybe I should go get that cardiac cath done because it's a lot less invasive than the FemPop we're getting ready to do for you. All right. Any other questions about that? All right. The next one is a female that's coming in for a little bit of gallbladder work, which again is kind of common. We see this happen pretty frequently. But this lady's a little bit different. She does have some commonalities. A lot of times what you'll see as far as cholecystitis is that they've had previous surgeries. Now, previous may not be immediately prior to this, like 2 weeks. A lot of times in patients that have had bariatric surgery in the past, they're increased risk for having to have a gallbladder out. You'll also see pregnant women seem to have a little bit of an elevated risk to have their gallbladder taken out. So that adds a little more stress to us. The good news is a lot of times, those patients have had an anesthetic and done okay since then. So this lady's 48. She's a little bit older as far as our gallbladder patients go. She's 2 weeks post-op, and she's had minimal ambulation. So when you see kind of those distinct words, when you get these little paragraphs or question kind of phrases, start thinking there might be a clue there. So she's had minimal ambulation since surgery. That worries me. Other things you'll see that they kind of put out there, minimal ambulation is one of them. And then the other thing you'll see is that there'll be like not a whole lot of medical history, but patient's on birth control, or patient's got some sort of coagulation issues. When you start seeing things like that, home in on it and get your brain thinking, hey, there's a high potential for this patient to have like a DVT or a PE since they've been kind of bedridden. Same thing with like orthopedic stuff. They've had fractures, they haven't treated them, or they've been bedridden since fractures. Those things tend to kind of start making you think this patient's higher risk for some sort of clotting issue. Past medical history, illnesses in the past, she's had none. Dig a little bit further into patients that have no history. Just make sure that they really have no history, because sometimes that no history is by virtue of they haven't gone to the doctor. Not that they don't have any medical problems, they just haven't had them evaluated. So she had that ACL repair 2 weeks ago with general anesthesia, no problem. So we're not quite as worried about any sort of PONV or MH in this patient. Medications, she's still on Tylenol with codeine. We talked the other day about issues with codeine. Not so much of a problem with adults, but we certainly worry about it in pediatric patients. No allergies, denies any sort of vices, so she's kind of boring from that perspective. No history of family issues with anesthesia. She's a little bit big. She's 106 kilos, a little bit tachycardic. Why is she in moderate distress? Is she in moderate distress because of her gallbladder? Is there something else going on? One thing I kind of start wanting to see that you notice is conveniently absent from this. You've got somebody that's been bedridden, they're fat, and there's no SpO2 here. She looks a little distressed. She's breathing fast. Like I said, is this from gallbladder pain or is it something else? One thing I always try and do on these patients before I give them any sort of sedative like Versed in the holding room is get a room air pulse ox. Because you'll see on the back end, you go to wake these patients up and you only get like a SAT of 92, 93, and you're like, wow, I really wish I knew what they were to start off with. Sometimes the pre-op nurses will get that for you, sometimes they won't. So if I hook up one monitor while a patient's sitting in pre-op, it's going to be that pulse ox. It gives me a heart rate, and it also lets me see where they are from an oxygenation standpoint. Because usually by the time you get to the room, you've already given them something that may decrease their respiratory effort. So that could result in your SpO2 going down. Airway looks good. Breath sounds are clear. Heart sounds good. Labs are kind of unremarkable. She's got good NPO time. Usually for patients that are having a gallbladder done, even if they're NPO, I would consider an RSI or a modified RSI. Modified RSI is where you not necessarily avoid or hold cricoid pressure, do like a quick induction, but you generally will avoid ventilating that patient till the tube's in. So kind of the sequence for you would be Versed and holding, fentanyl lidocaine when you get in the room, then propofol followed by your succinylcholine or rocuronium, and then trying to achieve those intubating conditions as soon as possible. So a minute or two without ventilation at most. Things for you to think about with that, make sure you've adequately pre-oxygenated the patient. And then, like when you guys get to clinicals, have a discussion with your preceptor. Just ask if they want to do a true RSI or if they want to do a modified RSI. You'll see a lot of the times we're just doing modified RSIs. They're not like true urgent intubations where you're holding cric pressure. You're pushing sucks and tubing them as soon as possible. So I would consider an RSI or a modified RSI for this lady, even though she's got a good MPO time. She's a little bit bigger. She probably has delayed gastric emptying. And then with her gallbladder not functioning properly, the last thing I want to do is see bile come bubbling up through that endotracheal tube or through those cords when I try and put it in there. So things to think about. We discussed that she may be elevated risk for PE. She's female. She's immobile. She's had recent surgical history. Sometimes you will see that people coming in for routine stuff, even something as simple as an ACL, may get a one-time dose of heparin. Usually it's like 5,000 units sub-Q the day of surgery, but they may not get anything at all. So that may help out a little bit with that. But if you do see patients that are getting it, usually that's why, is they're trying to reduce their risk of any sort of thromboembolism associated with their surgical procedure. So from an anesthetic standpoint, like I said, she's a little bit big because of that and her delayed gastric emptying. She may be a little bit elevated risk for aspiration. We may have some trouble oxygenating her because of her size. And again, because of the obesity, she may have a little bit elevated risk of thromboembolism. From a monitoring standpoint, I don't think we need anything special. I wouldn't put an arterial line in this patient. Just get her well pre-oxygenated. I can't emphasize to you guys enough, when you get to clinicals, pre-oxygenation will be your friend. As soon as you get that patient in the room, even before you get your monitors on, get them pre-oxygenating. Because if you can pick up an extra 3 to 5 minutes of breathing that 100% oxygen, it will benefit you every time. You don't even have to hold it on their face. You can ask them to hold it. You can just set it near their face. If you're just increasing the saturation of the oxygen around their face, that's still better than breathing 21%. So get them intubated. If she's big, you may consider having a video scope available for you. When we looked at her airway, we didn't see that there were any problems there. Maintenance phase, she should be pretty straightforward. A lot of times gallbladders aren't that painful. Usually the surgeon will infiltrate the site where he's going to put his ports in with local anesthetic, so that helps with that. The biggest pain these people usually have is just from the gas. Post-procedure, they may complain of a little bit of shoulder pain. They may have some abdominal pain. Sometimes at the end of the case, the surgeon will go ahead and suction all the gas out they can. Patients really appreciate that. On the wake up stuff, if you're concerned about her being aspiration risk, I would probably make sure she's wide awake before you extubate her, or at least able to protect her airway. So what happens? She starts having some difficulty breathing, some tachypnea. We see hypoxemia because of the VQ mismatch. A lot of times in these patients, you will see hypocarbia because they're ventilating a lot faster than they're perfusing, because they've got that dead area there. So you'll see a large gradient that occurs due to the dead space. Depending on the size of the PE, tachycardia is extremely common for all these patients, but you may also see that they develop pretty impressive hypotension. If for some reason you were to be monitoring CVP, you would see that because of the RV failure, that your CVP is elevated. If you're not monitoring CVP with a central line, other things you can look at, take a peek at the patient's neck. See if their jugular veins are distended. You can throw your ultrasound on the neck and see what the IJ looks like. You can also slide it down to the heart. You may see that right ventricle is pretty distended, just by virtue of the fact that it's having a hard time perfusing the lungs because of that clot. And that's something you can do with kind of a basic ultrasound knowledge. It's not like you have to go down and get a big measurement. You'll look down there and you see that the right ventricle is just very large. So things that we talked about for her as far as like risk factors for the DVT, she's had vascular injury because of her surgery. She's been immobile. She's a little bit older. She's obese. We don't know about any sort of cardiac issues or any sort of oral contraceptive, so she's got that going for her. So from a hemodynamic standpoint, what you'll see is that PA pressure goes up because the heart is still trying to achieve that same level of perfusion, even though it's got this blockage going into one of the pulmonary arteries or pulmonary arterioles. From there, you tend to see that the right ventricle fails, which is going to result in an eventual decrease in your cardiac output. And as I said, you're going to see your CVP goes up. So how do we take care of this patient? Because again, this is a very real possibility. And under anesthesia, a lot of times it's a diagnosis of exclusion. We may not know what's happening. You may just have this patient present with hypoxemia. So first thing is to maximize oxygenation. If the patient is intraoperative and you're fairly certain they've had a PE, you can start off with loading them with heparin. Usually we'll do like a 5,000 unit dose and then follow it with a drip. And the reason we do heparin for a lot of these patients initially is because that we can easily reverse it. So you also have to think about where they're at in their surgical procedure. While having your gallbladder taken out is kind of minimal, you do have an increased risk of bleeding. So kind of the initial treatment is something that we can take care of if we do start to have a large amount of hemorrhage. Continuing down the pathway there, we're going to have to maintain hemodynamics. Be very cautious about large fluid boluses because it's going to increase your right ventricular strain. But for your initial treatment, that may be beneficial. Inotropic support, again, you can consider dopamine, dobutamine, or norepinephrine. A lot of times now we're just going straight to norepinephrine in almost all of our shock states. There's some exceptions, but it's primarily going to be a norepinephrine or a vasopressin. And then finally, what are we going to do with this patient? It's going to turn into some sort of how do we get the clot taken care of or get the clot out. So initially we want to have a good diagnosis. So we're going to get them down for a CT with contrast. to take a look and see if they do have a clot in there. If they do, the next treatment's going to depend on the capabilities of the center you're working at. So if it's someplace where you have a pretty productive interventional radiology department, they may take them over there and do some sort of embolectomy, where they'll actually go in and suck out the clot. Depending on the size of it, that may not be possible. They may also consider doing systemic thrombolytics or catheter-directed therapy. And as far as whether it's systemic or catheter-directed, it really depends on the preference of whoever's treating the patient. Some places, the intensivists or the pulmonologist are real big on catheter-directed stuff. You may not have that option available to you, again, if you don't have IR capability or kind of aggressive IR capability. So the good news is that it seems like systemic thrombolytics are almost as useful as catheter-directed therapy. All right, so what questions did you guys have about this one? I know it seemed like it was going to be a really straightforward case, and then you had other stuff thrown at you. Forrest asked, why did it call for an inotrope? A lot of times what you'll see in these patients with the RV failure is that they become profoundly hypotensive. Kind of the classic presentation of a PE is hypoxia. There's kind of varied references as far as where you see the hypoxia. So some people will tell you SpO2 no greater than 90. I've also seen references that say an arterial PO2 no greater than 70. Other places say an arterial PO2 no greater than 100. So hypoxia in the setting of kind of maximum oxygenation makes you start thinking that they've got a PE. So from that standpoint, maximize your oxygenation, and then you're going to have to start doing something to support that heart. The fluid boluses generally are problematic because it increases your right ventricular strain. Kelly said, when you maximize oxygenation with these patients, do you turn down your gas also? It depends. There's not a good answer to that. So those are kind of two independent things. As far as maximizing your oxygenation, that's going to be dependent on your FiO2. Now, what you may see is that by decreasing your gas, you lose a little bit of the bronchodilatory effects, and you may have a little bit of vasoconstriction, so it could be problematic. But what you do with your volatile is going to be more dependent on the patient's hemodynamic standpoint. So say, for instance, patient suddenly becomes hypoxic and hypotensive. Even without thinking about PE, I'm going to start turning down the gas, because that's going to be the biggest thing I can do to control my hemodynamics at that standpoint. You still want to keep your patients sedated or at least amnestic. So hopefully we've given some Versed up front. If not, I would certainly consider giving them some ketamine at that point. But you're going to have to titrate your patient's gas down until you're able to get something in their system that brings their blood pressure up. So if this is intraoperatively and we think the patient's developed a PE, I would go ahead and get them to finish as fast as possible. The nice thing about this is it's not a very involved surgery. Most of these cases take 30 to 60 minutes at most. And if they're at the point where they don't have ports in, great, we can stop. If they've got ports in, they can just pull them out. And even if they're at the point where they're already dissecting the gallbladder, they can always stop and come back in, but it depends on the surgeon. One of the other things we didn't really talk about in this case that you may see happen is not so much a venous thromboembolism, but these patients can also develop a CO2 embolism. Sometimes when they, either through just the CO2 absorbing into the tissue itself, or when they put those ports in, sometimes they'll inadvertently puncture a smaller vessel or sometimes a larger vessel. I've seen patients that had CO2 infused into their liver because they put a port into it. So kind of to take you guys through the process of a laparoscopic surgery. They get the patient all prepped. Depending on what they're doing, it kind of helps them figure out where they're going to put the ports. But almost always the first port is going to be right around your umbilicus. So they'll take a couple of retractors, they pull up on the umbilicus, they make a small incision in the skin, and through that they bluntly insert the port. If you haven't seen a port, it kind of looks like big nail with a big round thing on the end of it. And then on the other end, by the kind of pointy part, there's going to be a cuff or a balloon that holds it in place. So they're going to use that to insert it. They may use the camera, they may not, as they're putting that port in there. And you'll see that a lot of these kind of variations of safety, like not using the camera when you're putting it in there, especially as you start putting in more ports. So you usually put in one port and then you follow it up with others. But most of your safer surgeons will watch as they put the other ports in. That's how you avoid putting ports into livers and intestines and things like that. So they put that port in there, and then they're going to insufflate, where they actually infuse the CO2 into the abdomen that distends it. So you can see how if you weren't watching what you were doing, and all of a sudden you start putting the CO2 into the abdomen, and you've put your port into a liver or an intestine or a bladder, any of those sorts of things, all of a sudden that's going to be filled with that CO2. Or an inferior vena cava. I've never seen an aorta, but I've seen pretty much everything else. So you can see how a direct infusion of CO2 would be pretty bad for that patient. It almost always results in immediate hypotension and about half the time like cardiac arrest. So pay attention to what the surgeon's doing, not just what's going on your side. But so, though, after a long answer, does that kind of answer your question, Kelly? That the oxygenation and the volatile anesthetic are two different things. You can maximize oxygenation without having any volatile going. All right, cool. Any other questions about this patient? And this is specifically talking about like a blood clot. Also think about this in orthopedic cases. You could have a fat embolism. We just talked about CO2 embolisms. So it doesn't necessarily have to be a clot. You can see these cases clot off for a variety of reasons. It doesn't necessarily have to be blood that's clotted. All right, any other questions about that case? All right, thank you for you folks that did those. I hope those were beneficial for you. And it's easy points on your exam. All right, so we're going to hop back over to our lecture. We're picking up where we left off, starting off with antiemetics. All right, so this is kind of a busy slide, but what I wanted you guys to see is that there's a whole lot of things we do that can cause nausea and vomiting and also treat nausea and vomiting. From a cerebral standpoint, a lot of the medications we use can cause nausea. Benzos can do it. Benzos can also help with it. Marijuana can help. Just relaxation techniques, talking to people sometimes can help with decreasing the risk of vomiting. From a vestibular standpoint, one of the biggest things we see is the patient's volume status. So patients that are hypovolemic, like maybe we made them stay NPO for 8, 10, 12 hours, or at increased risk of vomiting, that's usually from the vestibular center. We can treat that with a variety of things. We can use histamine agonists. We can use anticholinergic medications. One of the biggest ones we use is scopolamine. Elevated ICP can cause nausea and vomiting. From that standpoint, a lot of times we'll try and address that with dexamethasone. So it not only works to help with brain relaxation, but it also helps decrease the risk of vomiting. So elevated doses there, like 10, 12 milligrams. From the chemoreceptor standpoint, you can look at dopamine antagonist. One of the biggest ones we use is metoclopramide. Although with that being said, low-dose Haldol is making a return. So you may see somebody that's getting like 2.5 milligrams of Haldol, 0.5 milligram of Haldol, and that helps out quite a bit. For PO stuff, you'll see a lot of patients will take prochlorperazine or chlorpromazine, and those work out well. A lot of, like I said, over-the-counter kits will come with that. You may see almost all our patients are getting ondansetron or Zofran, pretty beneficial medication for those patients. Moving on down to the GI tract itself, again, metoclopramide is the most common medication we use that works on the GI tract. So there's a variety of things you can do. the most important thing, and we're going to go through these in a little more detail, is to have some sort of antiemetic plan for these patients. Nausea and vomiting is a huge dissatisfier for patients. The two biggest things they usually worry about from an anesthetic standpoint are pain and nausea and vomiting. So you'll see some people are kind of minimalistic and they skip out on giving medications to a patient until there's a problem. I would much rather my patient not to get to recovery and vomit than me give them some Zofran. So this is just a quick rundown of a lot of the medications we use. Decadron is one of the more common ones, and it works well not only for nausea, but it's also pretty beneficial as an anti-inflammatory agent. I usually give Zofran and Decadron to all my patients. They'll get 4 to 8 milligrams of Decadron, and then usually 4 milligrams of Zofran. And I have almost no PONV in patients I don't expect to. And generally, if I have a patient with PONV, I go full court press to avoid them having these sort of issues post-procedure. One of the bigger things, just avoiding triggering agents and kind of tailoring my anesthetic. But you'll see just by recognizing your patient's high risk for PONV and treating them that they generally do pretty well. Moving on to Zofran, it's pretty safe medication. We do have to worry about QT interval increasing, but it's not a whole lot of, it's not a common problem. There is a warning out for Zofran, but you'll see like in chemotherapy type settings that they commonly will give 16, 20 milligrams of Zofran. So our 4 milligrams is not a big deal. Zofran is a very effective anti-nausea medication, but you'll see if patients get to the point where they're already vomiting, Zofran doesn't help out a whole lot. So it's more of a prophylactic medication than a treatment medication. Droperidol was the go-to for the longest time for nausea and vomiting, and then because of the black box warning over its QT lengthening, it kind of went out of favor. It's now making a comeback, so we're starting to see it more and more, but it can still be pretty tough to find. Things to watch with that, again, watch your QT interval. You may see that it causes a little bit of sedation and confusion, but usually that's going to be at higher doses. For Reglan, we'll use that in our increased risk patients. A decent number of my diabetic patients will get Reglan because generally the diabetic patients have problems with gastric emptying. So if I give them Reglan, it kind of counteracts the effects of that. One thing I would encourage you to worry about with your Reglan is don't give Reglan fast and don't give it to somebody that's wide awake if you can help it. You'll have a severe onset of anxiety and extrapyramidal side effects in these patients. I had a partner that gave somebody a Reglan one day pre-procedure for surgery, and they were concerned and confused enough almost to the point where we had to cancel the case in pre-op. He was able to calm them down, but just be very cautious about getting Reglan to people that are wide awake. Benadryl, we talked about it a little bit the other day, but it works really well for the histamine receptors. If I'm giving Benadryl as part of a PONV cocktail, a lot of times I'll just give a lower dose. So like 6 1/4, 12.5 milligrams up front. As I mentioned, it does help out a little bit with those secretions, so they'll be a little bit drier for you. If you give like 25 or 50 milligrams, you'll see some sedation in your patient. Maybe that was what you were looking for, so that's okay. A lot of times if I'm giving it for PONV, it's part of a whole bunch of other medications I'm giving, so I try not to give high dosages of it. Scopolamine patch is very effective for those with motion sickness. You'll see that a lot of times we will put patients on a scopolamine patch for several days, so they may get a new patch every 24 hours. One just kind of thing for you to think about with scopolamine, for it really to work, it's got a delayed onset if you're giving it as a patch. So we really need to have these patients getting that scope patch on either that morning before they come to the operating room, the night before. Putting a scopolamine patch on somebody when you're rolling them back to the operating room is just not real beneficial. Unfortunately, that's the common practice. So the downside of that is while scopolamine works pretty well for nausea, you will see, especially in elderly patients, it causes confusion. So if I have an older patient, I will never use a scope patch on them, even if they're high risk for PONV, because it just isn't worth the confusion and problems that come out of it. You also have the risk of some urinary retention with scopolamine. There used to be an IV formulation of scope that was available, and then it went away. I think it's still available in some European countries, but I haven't seen it in the United States in quite a while. But you may see that come around too, just depending on where you go. The other thing is remind your patients if you do put a scopolamine patch on, or like if you send them home with another one, make sure they're taking one off before they're putting it on, putting the second one on, or they're just taking it off in general. Otherwise, they're going to continue to have effects for days. Pepcid's histamine blocker, you'll see that even though it primarily decreases the gastric acid, it also can reduce the nausea and vomiting. It is FDA approved for morning sickness, but you'll see that Zofran is the most common medication given to pregnant mothers. You'll see patients that were concerned about aspiration pneumonitis, that we're going to go ahead and give Pepcid up front. Usually you give it 20-30 minutes ahead of time to try and reduce that gastric acid level. For Phenergan, Phenergan's primarily a rescue drug. So like I said, a lot of these things we're going to give for nausea, but Phenergan actually works pretty well for patients that are actively vomiting. Things for you to think about, it does tend to have some sedative effects. If you're administering it, please make sure you dilute it. It usually comes 25 milligrams in a vial, and I'll go ahead and dilute it down to 10 mLs if I don't put it in a 50 ml bag. Again, dosage-wise, start on the low end, and you can always give a little bit more. So kind of like 6 1/4, 12.5 milligrams there. Very rarely will I give 25 milligrams. I think back to like when I was in the ER and we used to give 50 Demerol and 25 Phenergan to everybody. And we've kind of come away from that point. Just like some of our other pretty caustic medications, extravasation can result in significant tissue damage. So make sure you've got good vascular access. We talked the other day about propofol and its antiemetic properties. As I said, I usually keep like 10 or 20 milligrams around on the way to recovery just in case they do have some nausea, vomiting. And you can use that as a TIVA if you do have somebody that you're thinking is high risk. A lot of times for those patients, if I have somebody that I'm thinking is high risk for PONV, start off with, I'll kind of give them the full court press. So pre-procedure, I'll give them Pepcid. On the way back to the operating room, I'll go ahead and give them a little bit of Benadryl. That way I've got the drying effects for my airway. After induction, I'll go ahead and give them Decadron and Zofran. And I may go ahead and give them a Reglan too. A lot of times what I'll do with the Reglan is put it in either a 50 ml bag, or like if I've got a little bit of the fluid bag left, put it in there so it's not going in real quickly. Other things, you can repeat your Zofran and Decadron. As I said, like for chemotherapy patients, they'll get 16-20 milligrams of it. So if you have somebody that's high risk or you have a longer case, I'll usually give a dosage post-induction and then another dosage about 30 minutes before we're done. Zofran usually takes about 30 minutes to work. So if you're only going to give one dose and you're not really worried about what's happening in PACU, you can give it up front. But I would probably try and target it about 30 minutes from emergence, since that's when I really start to worry about nausea and vomiting. And then infusion-wise, I'll usually run them on propofol, dexmedetomidine, and then I'll use ketamine, magnesium, and lidocaine for pain. Or some sort of regional anesthetic. So I try and avoid opioids if at all possible for those patients. Newer medication we're using, Emend, is a nice antiemetic drug. It works extremely well. The downside is it's very expensive. So a lot of hospitals have restricted its use to those patients, which are kind of high risk for PONV. But you may see that come around as well. All right, any questions about PONV stuff? Again, like I said, nausea and vomiting is a huge dissatisfier for patients. So if we're able to give them a couple medications prophylactically and prevent that from happening, it's extremely beneficial for them. All right, so we're going to move on to paralytics. Again, another common medication we utilize. So neuromuscular blockers have been around for a long time. Kind of the earliest reports came out of South America, where some of the Amazon tribes used curare for hunting. So think about those blow darts with like curare on the end of them to drop animals. From a surgical relaxation standpoint, the first successful case occurred in 1912 Key thing there is successful. So think about all the people beforehand that had unsuccessful administration of neuromuscular blockers, and especially before we really understood what we were doing. Maybe they weren't getting enough ether with it. So lots of bad things going on there potentially. And the reason I mention that is that there's a lot of risk that comes along with neuromuscular blockers. If you think about it, if you go to death row for an execution, you're going to get 3 medications usually. One of them is going to be a sedative. So it used to be thiopental. Now a lot of places have gone to Versed or a Versed-Dilaudid combination. The next medication you're going to receive is a paralytic. Most places are using either vecuronium or pancuronium. And then finally, potassium chloride to stop the heart. So if you think about an anesthetic, we're doing 2 out of 3 of those, and sometimes 3 out of 3. So keep that in the back of your mind while you're doing things. There's a lot of risk that goes along with anesthesia. They used it in the 40s in Canada for a patient that was having an appendectomy. And since that time, we can use them for a vast majority of our anesthetics. So pretty common medication. So a couple of different kinds we use. Succinylcholine is the only depolarizing neuromuscular blocking agent we use. I would make sure you know that because you're going to see it again and again and again. With that being said, part of the problems that we see from succinylcholine come from the depolarization. So what you see happen is that patients have this immediate bump in their potassium levels. So if you have somebody that's long-term burn, greater than about 24 hours, somebody that is upregulated for some reason, maybe they're bedridden from a stroke or from multiple sclerosis, something like that. Patient with renal failure that already has an increased potassium level, you may see that by giving that succinylcholine, that little bump in potassium may be enough to cause arrhythmias and arrest. The book answer for how much change you see in potassium is only 0.5 milliequivalents per liter. But if you have somebody that's already hyperkalemic, that may be enough to tip them over the edge. Now, for the normal renal patient, it's not going to be a big deal, but you'll see a lot of times it still gets avoided as far as administering the medication. So onset's pretty quick, 30 to 60 seconds. Duration of action, 7 to 10 minutes is the book answer, but you'll see a lot of times it's even shorter than that. Dosage-wise, IV, usually you're going to give 1 to 1.5 milligrams per kilogram. Most of the times it's going to come in this 20 milligram per ml, 200 milligram vial. So you're getting 10 milligrams or 10 mLs of Sux. It usually requires refrigeration, but can be out for up to a month. So pretty common medication we use. Things for you to think about. You may see that it's antagonized by using non-depolarizing agents. So you may see somebody is kind of pre-treated for defasciculations. You may give 5 to 10 milligrams of rocuronium or a milligram of vecuronium prior to administering your succinylcholine. That way they don't fasciculate. You can also accomplish the same thing by giving a 1/10 dose of succinylcholine about 30 to 60 seconds before you give your full strength dose. So say I wanted to give somebody 100 milligrams of succinylcholine for induction, I may give them 20 milligrams along with my propofol, and that way I can avoid the defasciculations or the fasciculation. Cis-atracurium or Nimbex is an isomer of atracurium, but it's about 4 times more potent. One of the other big changes between cis-atracurium and atracurium is that you don't have histamine release. One of the big downfalls of atracurium is that histamine release, which does cause hypotension. You get very little dosage change with age or illness. It doesn't accumulate. Your dosage is fairly low. So like I said, for pancuronium and for vecuronium, 0.1 milligrams per kilogram. Usually for Nimbex, it's going to be 0.2 milligrams per kilogram. Usually it comes in a 20 or a 10 or 20 ml vial, depending on where you're at. It has to stay refrigerated up to the point where it's administered. So Sux and Rock are refrigerated, but they can be out for a while. Nimbex needs to stay refrigerated up to the point where it's administered. So part of the reason that we use Nimbex is for patients with renal failure because you're not dependent on that renal metabolism because it's metabolized by the esterases. So it doesn't depend on organ function. The other side of that is if you have somebody with renal failure, a lot of times for metabolism, it'll kick over to the liver. So like if I give somebody rocuronium, but they have renal failure, the kidneys may not be able to metabolize it quite as well, but a lot of times the liver will pick up the slack. So you may see somebody, even though they have renal failure, if it's not extreme renal failure, may still get rocuronium. Problems you run into with Nimbex, it's far more expensive than the other muscular agents we use. And the other thing you're going to see is that it's, I don't want to say useless, but you don't get a whole lot of relaxation out of it. It wears off very quickly, and you don't get the same profound motor blockade that you get with the other medications. So Nimbex works, but I will generally use something else, even in patients with renal failure. And part of that may just be avoiding paralysis altogether. Maybe I just use propofol for induction. Maybe I, like I was talking about the other day, use remifentanil, something like that, just because it doesn't work very well. Vecuronium was our kind of go-to long-lasting non-depolarizing agent for the longest time. And then as rocuroniums come onto the scene and become more and more common, we use that for almost everything. Intubation dose, again, is 0.1 milligrams per kilogram. It's supplied in a vial, which is a 10 milligram vial. You're going to have to reconstitute it with 10 mLs of sterile water to give you a total concentration of 10 milligrams, which is 1 milligram per ml. Primarily used as a bolus. You can also use it as an infusion, but we don't do a whole lot of paralytic infusions in the operating room. That's more of an ICU thing. We tend to just do push dose boluses for patients. Caution for patients with hepatic issues, because it's primarily metabolized there. So if you have somebody that's got liver or hepatic failure, you may see that they retain a large portion of the metabolites. So I would consider decreasing your dosage, and especially if you're going to redose, make sure you've had good return of your train of 4 before you administer additional dosages. Rocuronium is the most common paralytic we use now. You have a dosage range with this medication. So 0.6 milligrams per kilogram is what you've learned the whole time. It's kind of cool because you get a dose-dependent onset. So at that lower end, you get a little bit slower onset, usually about 2 minutes. If you go up to the high end, which is the RSI dose, if you will, of 1.2 milligrams per kilogram, you'll see it sets up in 30 seconds to a minute. So almost the same onset that you see with succinylcholine. So you've got quite a variety there. With that being said, you can calculate out the patient's dose, but you'll see commonly 50 milligrams is used for patients with induction for kind of the traditional, because that covers almost all your patients. You will also see that you get kind of strange reactions out of rocuronium. There's 2 medications that we see weird things happen with. The marcaine that comes in the spinal trays that we use for OB, and then rocuronium. And there's never been a whole lot of great research that's proven why it happens. Some people kind of theorize that, you know, the rocuronium gets set out on the back loading dock and gets hot or something like that. That's been disproven, but the urban myth of anesthesia still sticks around. So you'll get what I call random rocuronium reactions. Like you give a perfect loading dose or a perfect intubating dose, and the patient doesn't achieve any sort of paralysis. You may also give that same dose to your next patient, and then they don't have any sort of return of motor function for 2 hours. So you'll see that that can be problematic for you. It's not such a concern now because we have Sagamidex available to us. When you were dependent on neostigmine and glycopyrrolate, it could be problematic for you because you had to wait till you had some sort of motor return to be able to reverse it. So you may see some random rocuronium reactions. My experience has been primarily if I had a random reaction, it was when I redosed, not with the additional dosing. So I usually give a little bit bigger dose up front and then avoid redosing if I can help it. Nice things about it, it has really no active metabolites. It's excreted unchanged by the kidneys as well as in the bile. So if you have somebody that's got renal failure, it's not such a big deal. And if you have somebody with hepatic failure, you may see a little bit of long prolongation. But as I said, it's primarily excreted by the kidney, so it's not such a big deal. Now, if you do have somebody that's elderly or pregnant, you may see that you have a prolonged duration of action in those patients. So it's not so much a don't use, maybe just reduce your dose or careful monitoring post-procedure for respiratory depression. So we've given these medications, case is ended, now we have to figure out how to get rid of them. So what happens is almost all these medications work somewhere at the neuromuscular junction. So whether the non-depolarizing agents essentially work as an indirect antagonist, or something like succinylcholine that's a depolarizing agent, is it actually goes in and it acts as acetylcholine, and as part of that, it causes the cell to actually depolarize. So you have two different mechanisms of action there. We don't reverse succinylcholine because there's nothing there. The succinylcholine has already been metabolized and moved on its way. We do reverse our non-depolarizing agents, so our rocuronium, our becuronium, our pancuronium. Cis-atracurium can be reversed, but usually because it's metabolized through plasma, it's already gone. So you will not commonly see that cis-atracurium is reversed. So as far as the medications we use to reverse it, these are kind of the old go-tos. Edrophonium is a backup. It was primarily used in peds. Neostigmine is by far the most commonly used medication. And usually if we use that, it's going to be in a dosage of 0.05 to 0.07 milligrams per kilogram. And onset with that is usually like 5 to 10 minutes. So when you compare that to something like Sagamedex, that's almost an instantaneous onset, you want to give it a little bit earlier. So don't be trying to pull your tube and then administer your reversal. Usually I'll administer mine as they're finishing closing. Other medications that are available, and the reason we really mention these, because we run into shortages of neostigmine sometimes. So you may not have neostigmine available. You may be at a facility that doesn't have Sagamedex available. So the next kind of most common one that you'll see is pyridostigmine. It's very rarely used. And really, like I said, it's only if we run out of neostigmine. And then the last one is physostigmine. You may also hear it referred to as antilirium. And we don't use this very commonly because it tends to cause delirium and confusion in patients. I had a resident a couple years ago in Shreveport that just really wanted to do it and see what would happen. And he talked to like 4 or 5 CRNAs, and finally he found one that let him do it. And I walked into PACU to see this patient standing up on the bed and screaming after getting it. So that was a life lesson for him, because then he had to sit in PACU for 6 hours and monitor the patient while they calmed down. So if you have to use it, certainly do, but no, there are other effects that go with it. The big reason I put this on here is you may see patients that come in from home that are on it. And as part of that, you may have a hard time achieving neuromuscular blockade because they've already essentially had the reversal agent. So just taking you through the medications, edrophonium is pretty quick onset, usually a minute or two. So when you compare that to like neostigmine or pyridostigmine, it's a lot faster. It's not as fast as Sagamedex. I told you neostigmine is a little bit longer. Pyridostigmine is even longer than that. And you will see that the onset is significantly affected by how profound the neuromuscular blockade is. So when you actually stop and look at the train of 4, if you have somebody that has like 3 out of 4 twitches, or 1 out of 4 twitches, or 2 out of 4 twitches, you may see that it takes a lot longer to reverse that than somebody that already has 4 very strong twitches. So that's something for you to think about. As you're doing your case management, you're getting a little bit closer to the end of the case. Do you really need to administer another dose of neuromuscular blocker to this patient, or are they okay with what they've gotten? Because you don't want to burn yourself on the wake up. Edrophonium duration of action is about 5 to 20 minutes. If you give a larger dose, you tend to get a bit longer effect. If you have to give a larger dose, think about using neostigmine, not using edrophonium. You get a more profound reversal effect from neostigmine than you do from edrophonium. Neostigmine generally lasts about 40 to 60 minutes, and then pyridostigmine lasts about an hour and a half. And the reason I put this on here is because if you have somebody that was maybe borderline weak when you reversed them, and you're concerned that they may have long-lasting effects from the medication, it's possible that your neuromuscular blocking agent may last longer than the reversal does. So that's something for you to think about. If you have somebody that's borderline weak, I would keep them in the recovery room even longer So like if I've given neostigmine, I probably won't want to keep them there over an hour because I know that's my usual duration of action. So if they're going to get weak, it will happen there, not in the car on the way home or after they get back up to the floor or something like that. So one of the downsides that come from the administration of almost all those medications is that you tend to see profound bradycardia. So to kind of balance that out, most of these patients are going to receive glycopyrrolate. It's got about the same onset as our neostigmine or a little bit faster, and it lasts longer. So we usually get our glycopyrrolate in a 5 ml vial, so it's 1 milligram and 5 mLs or 0.2 milligrams per ml. Nice things about it when you compare glycopyrrolate to like Benadryl or some of the other anticholinergics, you don't see sedation from it. It doesn't cross the blood-brain barrier. What it will cause is tachycardia. Matter of fact, intraoperatively, a lot of times we'll use glycopyrrolate to treat bradycardia. It causes bronchodilation. That's usually helpful as patients are starting to wake up. And then, of course, one of the other nice things is we're giving it to help dry up secretions. So when you start looking at the anticholinergics you can give, glycopyrrolate and atropine are the two most commonly available. The nice thing about glycopyrrolate is, as far as the heart rate changes, you don't have quite the same tachycardia you see with atropine. Now, on the other hand, if you had somebody that was profoundly bradycardic and maybe hadn't responded to stuff, you may consider using atropine. Or if you don't have glycopyrrolate available, you may have to use atropine. So we use this paired with neostigmine because the neostigmine does cause the bradycardia, and it can progress almost to the point of asystole if it's severe. So what'll happen, say I'm giving a patient 5 milligrams of neostigmine, that's my calculated dose. I will then give them an equivalent milliliters of glycopyrrolate. So if I were to give them 5 milligrams of neostigmine, it's 5 milliliters. I will also give them 1 milligram of glycopyrrolate, which would be 5 mLs. So I'm giving 5 mLs of neostigmine and 5 mLs of glycopyrrolate. You may see that in some patients, especially those with existing cardiovascular disease, to avoid too much tachycardia, you may reduce that by 1 ml. So say, for instance, in that same patient, I didn't want the same tachycardia. I may administer 5 milligrams of neostigmine and 0.8 milligrams or 4 mLs of glycopyrrolate. Some people do that for all their patients. Some people only do it in specific patients. A word of caution for you, don't do that in any of your pediatric patients. Always give them a full reversal. They're just so heart rate dependent because of that fixed ventricular volume. And they also tend to have exacerbated vagal tone. So you worry a lot more about bradycardia in those patients. So kids always get a full dose. So Gamodex is one of the newer medications that we're using for neuromuscular reversal. And it's been out for about 5 or 10 years now. And it works pretty cool. It's only FDA approved for the use with rocuronium and vecuronium. It does work with PENK as well. But basically the way this works is it goes out and encapsulates the rocuronium or vecuronium molecule, making it inactive. So it works a little bit different than neostigmine because it doesn't inhibit the anticholinesterase. So you don't have to worry about the bradycardia. So if you have somebody with cardiovascular disease, you may consider Gamodex as opposed to neostigmine, where you have to give the Robenal atropine because you don't have to worry about the heart rate changes. You tend to see less adverse effects with Gamodex than with neostigmine and glycopyrrolate. But with that being said, there have been some reports of bradycardia and asystole with rapid administration of Gamodex. So you may consider pushing it slowly, which is kind of hard because it's usually 100 milligrams per ml. So pushing like 1 or 2 ml slowly can be kind of problematic for you. As far as the supply, you'll see that it's usually in that 2 ml vial, or there's also a 5 ml vial out there. And it's dose dependent as far as how much you're going to give. And it also depends on the effect, the current like neuromuscular return you have in these patients. So when you start looking at it, the official answer as far as how much you administer If you've got somebody with kind of a shallow to medium blockade, you're going to administer 2 milligrams per kilogram. On the other hand, if you have somebody that has like a pretty deep blockade, you're going to administer 4 milligrams per kilogram. So you may see that again. Just know that everybody doesn't get 100 or 200 milligrams because that's in the vial. There's an actual weight-based dose. But in clinical practice, you'll probably see that if they're going to get 150 milligrams, they're probably going to get the whole 200. But this is the actual dosage for you. The other nice thing about Sagamedex, if I have somebody that I RSI and I give them that 1.2 milligrams per kilogram of rocuronium, and then I have a failed airway where I'm not able to ventilate, I'm not able to intubate this patient, I can go through and administer 16 milligrams per kilogram of Sagamedex and get immediate reversal. The only downside of that is, one, you have to have that much available. So if you think about that patient that was getting 200 milligrams, now I've got to have 8 vials to be able to get them to that 16 milligrams per kilogram. On the other hand, that's definitely better than being dead. So just think about your situation, what you have available for you. Downside, it's very expensive, especially when compared to neostigmine and glycopyrrolate. Some facilities do not have it available at all. Other facilities, it can only be used kind of as a rescue drug, so like that can't intubate, can't ventilate situation. Or if you have somebody that you have given neostigmine and glycopyrrolate and have not had return, then sometimes you can give Sagamedex. Other places, it's only for select patient populations. So patients with pulmonary disease, patients that are morbidly obese, a lot of times there's a BMI criteria associated with it. Patients that have had longer anesthetics. So think about somebody that's been asleep for 4 or 5 hours, and then sometimes, or as I said, you can use it for emergent reversal. And it really just depends on the facility. Some places they use it for everybody. Some places they're really strict about who you can use it. And some places you don't have it at all. All right, so I'm going to kind of take you through the traditional anesthetic, and this is just to go through and make you think about these things. So usually in pre-op or on the way to the operating room, the patient's going to get Versed. Usually it's 1 to 2 milligrams, but it depends on the patient. Everybody doesn't need Versed. If you have somebody that's already calm and they're doing fine with things, there's no reason to give them an extra medication. On the other hand, if you have somebody that is extremely anxious, you may see that you need to give them more than 2 milligrams. That's not quite adequate. So really let your patient drive things. And sometimes, they may need something else. Ativan, especially if you have somebody that's on scheduled benzos, they may need something more than that as well. You can also consider giving them Precedex or fentanyl up front to help them relax. When you get to the operating room and start your induction, lidocaine for help blunting the sympathetic response as well as pain from your induction agent. Remember, like I said, propofol and etomidate both burn. Fentanyl, it's not just for the pain, it's also used to help blunt that sympathetic response. Think about why you're using which induction agent for these patients. Don't use propofol for everybody, or imamidate, as I can't spell, obviously. Different patients need different medications. So propofol is obviously the most common medication we use, but no other patients that may need other medications. Like I said, I use etomidate for almost all my bad hearts. Some people use etomidate for all their sick patients. Think about somebody that may benefit from ketamine. Maybe they're already hypotensive. Maybe you have an asthmatic you're inducing and the bronchodilation would be beneficial. So think about all those different benefits. Don't just get a cookbook for everybody. Tailor your anesthetic to all these patients. So as far as the TIVA, there's a lot of different options that come into play. When we were discussing the PONV, I kind of went through and talked about my cocktail for that. The other thing you'll add, especially if you're doing more of a traditional TIVA, remifentanil or sufentanil, just because a lot of times that analgesic benefit is a little bit better than using 5 or 6 different medications. And it also comes down to your comfort level and how much time you have. So kind of tailor your anesthetic for each patient. Same thing with your paralytics. Even though we use rocuronium the most common, there are other times that it may be beneficial to use something else. If I have a long orthopedic case or I've got a patient from the ICU, I may use pancuronium just because it's cheaper. It gives me a longer duration of action. On the other end of things, if I have somebody that maybe is high risk for aspiration. Think about your GERD patients, think about diabetics, somebody that's morbidly obese, that otherwise I would use an LMA for the case. I may consider using succinylcholine to place an endotracheal tube and then just letting it wear off and letting them breathe on their own. So there's a lot of variety for why you do what you do. If you're in one of those kind of fits and spurts where you're getting those random rock-uranium reactions, I may stop using rock altogether and just go to VEC because it's a lot more predictable. Some people have been burned enough that they won't use rock at all and they use VEC for everything. You guys, when you get to clinicals, really need to go out and experiment with all these different medications so you can establish comfort with them, because you never know when something's going to happen and you may not have this medication available to you, or you may have to use it for another reason. So during the case, titrate in longer acting pain medications if needed. If you've done something multimodal like PO premeds, ketamine, lidocaine infusion, regional stuff, they may not need something long lasting. But if they do, go ahead and start titrating those in during the case if you can. Antiemetic agents, as I said, usually I'll put those up front if I can. But remember, there are potential side effects for these things. So sometimes giving 4 or 5 antiemetic agents is not necessarily good. You may be able to get by with just a little bit of Zofran and Decadron. And then finally, on the back end of the case, you're going to go ahead and administer your reversal agents. So the medication you administer depends on what you have available to you and the patient setting. So as I said, neostigmine generally takes a couple minutes to take effect. So I'll administer that while they're closing. On the other hand, Gammadex is nearly instantaneous, and you tend to see not necessarily violent, but a lot more profound emergence from neuromuscular blockers when you use Gammadex. So while people tend to wake up pretty comfortably from neostigmine and glycopyrrolate, Gammadex you may see because they have a more immediate return. They start coughing, moving, that sort of thing. So if you administer that while they're trying to close, surgeons will not be your friend. So think about what you're doing as you move through things. To kind of wrap up, there's a whole lot of different ways to skin a cat. Be familiar with all of these. When you're in clinicals, please do see and try as many different things as you can. There is no one right answer for any of these patients, but you need to be able to adapt your anesthetic to whatever the situation may be. Go out, work with different people, learn different anesthetic techniques. When you first get to school, you're going to come in with kind of this cookbook recipe because that's all you know. Over time, you're going to start to figure out how you can kind of tailor your anesthetic to this patient and that patient. You will learn something from everybody you work with. Sometimes it's something you love. Sometimes it's something you'll never do again, and you're not really sure why they do that at all. But you take away little bits and pieces from everybody. As you get further through clinical residency, you'll kind of start to develop your own anesthetic style and practice. And that's good, but you kind of get into a point where you get frustrated because you figure out what you want to do, and you may work with somebody as a preceptor one day who always does one of those things you hate to do. You can always talk with them about possibly changing their anesthetic technique, but you'll figure out as you get to that point kind of who you want to work with and who you don't want to work with, because it's almost like you're flying on your own. At that point, you need somebody back there as a backup pilot, but you ought to be able to do everything on your own, and that's what you really want. You want people to be hands-off as you get a little bit further into clinicals. On the other hand, when you're up front, you need a little more guidance. You have questions about things. You're not sure about medications. You want to know, hey, should I do this? Should I push this? So you'll see that transition as you kind of move through clinicals. You'll see that there's, like I said, a lot of different ways to perform an anesthetic. Some are not necessarily wrong, but could probably be better. You can use lidocaine for lots of things. You can use it for pain relief. You can use it to infiltrate for local. You can use it as part of your regional blockade. You can do the same thing with magnesium. You can use it as a bronchodilator. You can use it as smooth muscle relaxant. You can use it as an analgesic. So there's lots of different medications that do lots of different things. So when you start working on your anesthetic plan, think about why you could do one thing versus another. Is a block more effective than a general anesthetic? It may be, it may not be. Like I said, we have one orthopedic surgeon that insists on all his patients getting general anesthetics, and then he puts a intra-articular cocktail into the wound bed. That's what works for him. It may not necessarily be any better or any worse than his partner, who does spinals for all his total joints, and we do nerve blocks. Both sets of patients have good outcomes. Some may be better than others, but you kind of have to weigh the risk and benefits for all those patients. So think about all these things. I can't go over all these choices in one PowerPoint. There's a lot of different variables that come into play: patient history, clinical setting, um, comorbidities. There's so many different things that there's not one single perfect fit for an anesthetic. You really just have to get out and start seeing, doing, and experiencing those on your own before you figure out what's going to work. And until you get to the point where you kind of have it figured out, you're going to be pretty heavily reliant on your clinical preceptor to kind of guide you. All right, so what questions do you guys have from that before we move into the other stuff that we didn't really cover? So you laugh about the gallon of prop, and it could be from MJ's mansion. But you'll see if you're doing a long TIVA case, especially on a large patient, you'll go through a pile of those 100 ml bottles. I think the most I've ever gone through in a TIVA case was 20, and it was a big patient with a lot of tolerance. Because a lot of times if you're doing TIVAs, those patients aren't going to get any sort of neuromuscular blockade. So you're dependent on your propofol and your remifentanil, not only for sedation, but also to make sure they don't move. So you may burn through them pretty quickly. All right, there's just a couple more medications we're going to cover that weren't in there, and then just a couple other different things. So one of the things I kind of wanted to follow up on with the PONV stuff, we have something called the APPLE score. So if you actually go back and look and figure out how many risk factors your patient has for PONV, it helps you guide how many antiemetics they can get. You guys want to take a break for like 2 minutes? We'll come back and wrap this up. Kelsey wants a break. All right, be back at 10:30. All right, we'll get wrapped up here. Richard asked, with those high doses of propofol, have you ever encountered propofol infusion syndrome? No, I haven't. whether it just wasn't long enough or, like I said, long cases are usually 5 or 6 hours, but I've never had any sort of problem with that. Yeah, Chris, I said that APFL score, and you'll see a lot of times that the APFL score will actually be calculated on your pre-op to make you think about, hey, this patient might be high risk for PONV. So that's kind of helpful for you there. So as far as it goes, like as you start increasing your number of risk factors, you basically start to double your chance of PONV. So the average patient has about a 10% chance of PONV. As you start adding risk factors, so like a female, age greater than 40, goes up to 20%. The reference on your clinical reference thing says, one medication, two medications. I tend to be a little bit more aggressive with that just because PONV is such a dissatisfier. So like I said, almost all my patients, whether they have any risk factors or not, will get Zofran and Decadron because of the additional pain medication benefit from that as well. But, certainly if you start getting up to your high risk patients, multiple medications, and I usually alter my anesthetic technique for those patients as well. So Roberto asked, when giving atropine after a reversal agent, would the dose still be 1 milligram? No, usually what you're going to do is going to decrease it down. It's not easy math. Usually it's going to be about 0.014 milligrams. The downside is you tend to see tachycardia in those patients if you give atropine. So there's really not a whole lot of reason to use it if you have glycopyrrolate available. But yeah, so it's not an easy math like the neostigmine and glyco. It's just 0.014 for each milligram of neostigmine or edrophonium. All right, so we're going to move on from that to some of the non-opioid analgesics. One of the most common ones we're using now is acetaminophen, and it comes in a couple different formulations. So you may see the patients are getting PO acetaminophen up front. So a lot of times we'll do a preoperative cocktail, and they'll get Tylenol, gabapentin, Celebrex, what have you. You can also give it intravenously. The trade name is Overmev. So either way, it's going to usually be about 1 gram that you're giving at one time. Pediatric patients, it's weight-based, but for adults, we usually just give them 1 gram. And you can repeat that every 4 to 6 hours. Generally, we try not to go too high, so no more than like 3 or 4 grams in 24-hour period. You can also give it rectally if for some reason you don't have the IV formulation and maybe they can't take PO or didn't get PO. Other things, Toradol or Ketorolac, lots of patients will receive this either preoperatively or intraoperatively. Dose is usually 15 to 30 milligrams. You will run into kind of some conflicting reports. There's a couple studies out there that show that when you get to 15 milligrams, you kind of hit a ceiling effect. So 30 milligrams may not be quite as beneficial. The other thing you'll see is a lot of times it comes in a 60 milligram vial. So you may see somebody give like 30 milligrams IV and 30 milligrams IM. Only concern you really run into with that is because it is an NSAID, you may have effect on platelet function. I usually wait towards the back end of the case to give it, even though the research has shown a one-time dose is not problematic. If I've got somebody that's bleeding, giving a medication that's going to alter their platelet function, probably not a good idea. Another thing you'll see is PO ibuprofen. It's called, the trade name for the nasal formula or the IV formula is Caldor. And usually we're going to do 400 milligrams of that, but you'll see that the dosage range is 200 to 800. Kristen asked 30 and 30 or 15 and 15. Usually if they do two, what they'll do is give like 30 milligrams IV and then another 30 milligrams IM, or like 15 milligrams IV and 15 milligrams IM. That way you kind of get the peak effect from it, but through the IM absorption, you get a little bit of a slower onset. Again, you see a variety of practices.
Hey, Doc.
Yep.
Hey, just confirm, because I always feel like the Toradol, like from my understanding, what you always tell us, it seems like surgery is always going to blame us. If the patient bleeds, we'll be blamed for it. And, obviously Toradol for the platelet dysfunction. So you're saying your rule of thumb is if the patient doesn't have an issue with bleeding, like intraoperatively, you'll give them the 15 milligrams in the back end to cover pain when they emerge?
If they've had a lot of bleeding issues, I probably won't give it at all.
Oh, bleeding
But
issues, not bleeding in intra. Like, I guess if they're bleeding heavily in intraop, then that kind of could be a
yeah,
bleeding
that's what I
issue.
mean by bleeding issues, like they've bled during the case.
Gotcha.
And if you're in doubt, or it's like a surgeon you don't work with, just talk to them. Some people, hate Toradol. Some people love Toradol. Just ask them if they're okay with the patient getting Toradol. That's not a big deal.
Okay.
Some surgeons
So-
always want you to ask. So, and especially when you're kind of coming into a setting and you may not have been there very long, or you're not familiar with kind of local practice, you can always just talk to the surgeon and make sure they're okay with it. Or like if ask your preceptor. Any of those things are fine.
Cool. Thanks, Doc.
Other medications we're going to go over. We've kind of gone through all the induction type stuff, all the analgesic type stuff. One of the things that we didn't really hit that I kind of wanted you guys to be familiar with is some of the cardiovascular medications. So the most common medications we use for hypotension are going to be ephedrine and neosynephrine. Ephedrine's kind of nice because you get alpha and beta effects. Usual dosage is going to be 5 to 10 milligrams, and it usually comes in a 50 milligram per ml vial. So then you're going to have to reconstitute it. A lot of times that happens just by taking a saline flush, spraying out 1 ml, and then drawing up the ephedrine. So then you've got 50 milligrams diluted in 10 mLs, which gives you that 5 milligrams per ml. It always has to be diluted. I can't say that enough. Neosynephrine and ephedrine are like two of the biggest medications we run into problems with in clinicals because people don't dilute them appropriately. You will kill somebody if you start giving full strength medications, and those two are really problematic. So there are very few vasopressors that we give non-diluted. Neosynephrine's the same way. It comes 10 milligrams in a 1 ml vial. If you're going to dilute that in saline, usually it's going to be a 50 or 100 ml bag. Sometimes you'll even do a 250 bag, just depending on what you have available. Make sure you dilute those two medications. Usual dosage for neosynephrine is going to be 50 to 100 micrograms. It just depends on how the patient responds. We usually start off with 100 mics, but if you give 100 mics and nothing happens, you can give 200. Or as I said, it may be somebody that's a little bit resistant. You have to give neosynephrine and ephedrine together. Same thing with your vasopressin. If you happen to be giving that to bring your blood pressure up, it's got to be diluted. Don't push it straight. We usually push a unit or two of vasopressin at a time. And it comes 20 units in an ml vial. Same thing, we'll dilute that to 20 mLs or 10 mLs, just whatever you kind of have available for you. But please make sure you're diluting those medications, not pushing them full strength. That's one of the most common clinical errors we see. For antihypertensives, and just one side note, you may go someplace where they have premixed ephedrine and neosynephrine, so you may not have to dilute it at all. Other places, they don't have those premixed, and you'll have like a neosynephrine bag, and that's your neosynephrine for the day, or like everybody shares or something like that. So just know whatever the practice is at your facility. So for antihypertensives, the most common medication we use is labetalol. Same thing, it may come premixed. You may have a 20 milligram syringe, or you may have to draw it up. Usual starting dosage for that's going to be about 5 milligrams. So same thing, you can give 5 milligrams and see what happens. If you don't achieve the effect you need, or you need to do a little bit more, you can always give 10 milligrams, 20 milligrams. Next medication we commonly use is esmolol. Usually comes 10 milligrams in a 10 ml vial, so you've got a total of 100 milligrams. Starting dose for that's usually about 10 milligrams. And then finally, the last one is hydralazine. Usually comes 20 milligrams in an ml, and same thing, we're going to dilute that down. So usually you've got 5 milligrams per ml. So when you're trying to treat somebody that's hypertensive, there's some things for you to think about. So kind of, as I said, your go-to medication is going to be labetalol. but you have to look at what's going on with the patient hemodynamically. So if you have somebody that has an elevated heart rate and an elevated blood pressure, labetalol is a good start because it'll address both those. If you have somebody that's just tachycardic, first of all, think about why they're tachycardic. And then usually we're going to use esmolol to address it if it's just a heart rate problem. But there could be other reasons the patient's tachycardic. Maybe they're in pain. You may need to consider, treating other things other than just giving them some esmolol to mask the symptoms. And then finally, if you have somebody that's hypertensive, but either bradycardic or close to bradycardic, hydralazine will not affect your heart rate like esmolol or labetalol will. The downside of hydralazine is it's a little bit slower onset. So it's pretty common that it takes 15 minutes to work. In anesthesia, we kind of want instant gratification or things to happen immediately. So don't rush and start giving more and more hydralazine if it hasn't taken effect. The other thing is hydralazine tends to last a little bit longer. So it's not our first choice medication because you never know. Maybe the patient is just hypertensive under anesthesia or with induction. And if you give them hydralazine, now you're going to be fighting that for the rest of the case. So those are kind of the situations we'll use those medications. Do you guys have any questions about those? Okay. You need to know those medications and their dosages inside and out because, like I said, people are going to ask you and you're going to have to implement it immediately. Even asked, have you seen problems with hydralazine and rebound tachydysrhythmias? I haven't, but it is a possibility. Part of the reason we may not see it so much under anesthesia is usually we've started off by treating them with something else and then they become borderline bradycardic. So that may be masked by esmolol or labetalol or something they've already gotten. But it is something that can happen. I just haven't clinically seen it. All right. Any other questions? Oops. Does the reconstitution for the common drugs vary significantly from facility to facility? Yes. You will see, for instance, JPS, we have our neosynephrine and prefilled syringes. But if I'm going to hang an infusion, for instance, I'll have to mix it. So our standard mix there is 10 milligrams and 100 mLs. When I was in residency, we mixed ours 10 milligrams and 250 mLs. So you got a concentration varying from 100 micrograms per ml with the 10 and 100 to 0.4 milligram or 0.4 micrograms, 40 mics in the 250 bag. So it really depends on where you go. I won't say it doesn't matter because if you're doing a case and I come in to give you a break, I may pick up your ephedrine and give it, not knowing that you've used a different concentration. So try and learn whatever the kind of common practice is at that facility just for safety. But it may vary. You may go to work today and there's no 100 ml bag, so you've got to reconstitute something in 50 mLs. So everybody should be reading the labels, but you still have kind of that normalization process. So people assume that you've mixed something the way they would assume it. It doesn't mean it always happens, but it was something I would definitely make sure you kind of follow the facility norm. Kate asked, for test purposes, do we have to know the vial concentrations that we have to dilute? No. If I want you to dilute a medication, I will tell you what the concentration you have on hand is and then how you dilute it or how you would dilute it. I'm not going to have you assume that you have X vial because there is quite a bit of variability as far as, vials. Really, the only common one that I don't think I've ever seen in any other way, shape, or form is that vial of esmolol. But you could get a bag of esmolol. Now, with that being said, if it's not something you're diluting, the concentration is usually pretty standard. But I will give you the information if I expect you to dilute something. All right. Any other questions? Go through, take a look at all the stuff as far as the exam content and make sure you're familiar with that. There's some practice math in there because people think about math differently. So, if one formula doesn't work real well for you, think about a different formula. There's not a whole lot of variation, but it may make more sense to you. Clarissa asked, for the exam, are we going on the TextWest Pocket Guide or the UCSF Pocket Guide? Testing will be off of the Wesleyan Pocket Guide. That's why we put it together for you. So that's kind of the standardization as far as medication questions go. But with that being said, you may get to clinicals and practice there is to do something different, or your patient has condition X, Y, and Z, and you have to alter that dosage based off of their clinical condition. It's really just a jumping point for you to kind of figure out where to start off with, and then you can start tailoring your medications to those patients. All right, anybody have anything else? All right, thank you guys for coming. If you guys think of any questions,